Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, our topic of discussion is about retinal detachment surgery following cataract surgeries. Cataract surgery, a very common procedure. Millions of people undergo this surgery and usually very safe. But sometimes patients develop this complication that is retinal detachment. So today we have requested a vitreoretinal surgeon from King Abdulaziz Medical City, National Guards Hospital, Dr. Nabil Refka. Dr. Nabil Refka is a consultant vitreoretinal surgeon over there. He did his residency and fellowship from Syria. I want to thank him on the behalf of my audience that he accepted our invitation and he came to here to present his talk. So now, without further delay, I will request Dr. Nabil Refka to present his talk regarding retinal detachment surgeries following cataract surgery procedures. Yes, Dr. Nabil.
Yeah, thank you, Dr. Alim, for the invitation and for the nice introduction. My presentation today will be about retinal detachment after cataract surgery. I don't have any financial disclosures. So let's start, as usual, with definitions. When we say that we have retinal detachment after cataract, we have two things. One of them is post-phaco RRD. What do we mean by post-phaco RRD? This means that the RRD happens within 1 year from the surgery. So, and according to some large studies, the incidence rate is around 1 in 500 cataract surgeries. So this is, on the other hand, we have something called pseudophakic RRD. So this means any detachment, rhigmatogenous retinal detachment, happening anytime after the cataract surgery. My focus today is about the RRD, which happens soon after our cataract surgery. So we will talk today about post-phaco RRD surgeries. Sorry, post-phaco rhigmatogenous retinal detachment. So let's go to the risk factors. White patients are affected more than black. Men, unfortunately for us, are more prone to have rhigmatogenous retinal detachment than women. For the age, interestingly, the age between 40 and 60 is the highest incidence of RRD after cataract surgery, and the incidence gets lower after 60. So this most likely because we have more PVDs and the vitreous is more liquefied after the age of 60. So peripheral retinal degenerations, if the patient has already lattice degenerations, snail tracks, atrophic holes, so white without pressure, all of these degenerations predispose any patient for retinal detachment. And in specific, if the patient undergoes cataract surgery, the incidence is higher to have retinal detachment than the normal population. High myopia, it's the same as peripheral retinal degenerations. We know that all high myopia patients are prone to have retinal detachment, and the risk is higher after cataract surgery. This is very important. If the patient mentioned a history of retinal detachment in the other eye, he is really at a much higher risk to have retinal detachment in the operated eye. Posterior capsule rupture and vitreal loss, complications. So we know complicated cataract surgery can lead to retinal detachment and increase significantly the retinal detachment rate. So according to this relatively recent study, it's 4 to 10 folds the risk of retinal detachment after a complication in cataract surgery. Okay, these numbers 4 to 10 folds. Why 4 to 10 folds? Is it always 4? Why 4 sometimes? Why 10? Why sometimes it's less? Sometimes it's even higher. So I will show you now two cases which will explain when do we have a higher incidence of rhegmatogenous retinal detachment or a lower incidence of retinal detachment. So let's start with this case. This case is a dense cataract, has been done by one of my residents, senior residents, but he noticed that there is a tilt in the nucleus. Let's start now. He noticed tilt. He checked. There was vitreous prolapse, and it's clear here by the Wexel. So he called me. What to do now? So deliver the nucleus as intracap or doing something. What I decided to do is to do pars plana vitrectomy approach, not to trace the nucleus, not to manipulate much the vitreous. So I inserted here, started with insertion of the trocars. As we see, the nucleus is dropping, is falling down. Okay, and this is okay, no problem. You see, it's falling now. Anyhow, we went for pars plana vitrectomy. It's very important to clean the anterior vitreous, not to cause any traction. We see the whole nucleus is on the retina now, small groove only. What we do, we induce PVD now. And then I injected PFCL to float the nucleus anteriorly. And after that, completing the vitrectomy, and we ate up the nucleus using the regular phaco anteriorly. As we noticed, this is a very dense cataract. What is the important step here is to examine the peripheral retina with the help of indentation. We did thorough examination of the periphery of the vitreous, as we see here. This did not show any peripheral retinal breaks, and we finished the case by inserting a 3-piece IOL. Okay, and this is at the end of our surgery. Okay, let's discuss here what is the risk of retinal detachment in this case. Actually, it's very minimal. We have a major complication, a dropped nucleus here, but still, did we manipulate the vitreous? Did we apply much traction on the vitreous? No, actually, we did our best not to manipulate the vitreous. This is number one. The other thing which is very important in this case, that we did internal search for any peripheral retinal breaks. And since we did not have any retinal break at the end of our surgery, the risk here, the incidence of retinal detachment is very minimal in this case. Let's go for another case. The surgeon here got a complication. We notice that there is vitreous in the anterior chamber, but he is trying to deliver these nucleus chunks. Okay, so we notice that they are not coming. These parts of the nucleus are not coming. This means that there is vitreous. They are stuck to the vitreous. So once you enter and try again and again, you are applying more traction on the vitreous, and this will lead significantly to a higher risk of retinal detachment. So we have now two cases, and we can clearly understand that sometimes we have a very high risk of retinal detachment after a complicated cataract surgery, and sometimes if the complication is managed well, the risk is lower. I'll move now to show you some of my cases where we have the retinal detachment, and we will study the risk factors for each of these cases. This is the number one case. This is a 63-year-old professor. He presented to us 3 months after a non-complicated cataract surgery. We notice this is a beautiful cataract surgery. Okay, but still, after 3 months, he presented to us with a visual field defect, and he had inferior temporal retinal detachment. We started with anterior vitrectomy. And we notice here we have inferior nasal retinal detachment with a horseshoe break. You see a very small horseshoe break. We removed traction from the vitreous on this break, and we ended up with airflow exchange and apply laser. Okay, let's study the risk factor for this professor. He doesn't have actually high risk factors. So he is above 60. He is not myopic. We examined the other eye. There is no peripheral retinal degenerations. So almost no risk factors, but still retinal detachment can happen. And this is very important. And this is only 3 months after the original uneventful cataract surgery. This is another patient, actually. This patient is a nurse. He underwent cataract surgery. Around 1 month only after the cataract surgery, he presented with vitreous hemorrhage. So we notice here, while doing the anterior vitrectomy, there is no red reflex because the patient has a vitreous hemorrhage. This is causing a dim red reflex. And he has here a giant retinal break superior temporally. And wherever you look in the periphery, you will see breaks. Okay, so let's study the risk factors for this patient. Number one, he is 40, he is a young patient. We mentioned that young patients might have young patients have a higher risk of retinal detachment than the normal than the population above 60. The other thing which is very important, we examined the other eye. The patient had extensive lattice and white without pressure in the other eye. And this explains actually why we saw a lot of retinal breaks all around 360 in the operated eye with retinal detachment. So we have risk factors in this patient, young patient, multiple areas of peripheral degenerations in the other eye. This is the last case. This is a young patient as well, 45 years old, 43 years old. He has high myopia, around 8 diopters. What is significant for this patient has history of RRD in the other eye. This was around 6 years prior to this surgery. He underwent a uneventful cataract surgery in this eye, and 6 weeks after the cataract surgery, he was referred to us with this bullous superior retinal detachment. And as we see here, and the break was hidden in the folds of the retina, as we'll see now. This is the only break we have. This is after applying laser on the break. Again, let's see what are the risk factors in this patient. High myopia, young patient. The last thing, which is the most important thing here, is the history of rhegmatogenous retinal detachment in the other eye. Let's have the take-home messages for this presentation. Rhegmatogenous retinal detachment can happen after any uneventful cataract surgery, as we saw with our patients. Risk factors should be discussed with the patients. As we saw with some patients, we have major risk factors like having a rhegmatogenous retinal detachment in the other eye, like having extensive retinal peripheral degenerations. So these patients, we should counsel these patients, sit with them prior to cataract surgery and discuss with them the possibility, even if it's not very high, but still can happen. This is very important. Good management of the cataract complication can decrease the chance of the retinal detachment. And on the other hand, if the complications were not managed well, this significantly increased the retinal detachment incidence. So for patients at high risk, okay, we mentioned the risk factors of retinal detachment after cataract. Suppose one patient is at high risk, has multiple risk factors for retinal detachment. So we need to sit with the patient and discuss the symptoms of retinal detachment. Once he has any, to present to ER. He has a new floaters, flashes of light, a curtain-like shadow, okay, visual field defect. So we instruct him to come immediately to the ER. And with this, I conclude my presentation. I would like to thank you again, Dr. Alim, and thank all of the audience here.
So thank you, Dr. Nabil. It was really very informative presentation for our audience. I just want to ask you a few questions regarding when you're a vitreoretinal surgeon, basically. So if there is a complication, for example, posterior capsular rent and lens drop and all these, what is your approach about in such cases when you do these vitrectomy and remove this? What is your approach about prophylaxis for the laser?
Okay, thank you, Dr. Alim. This is a very important question. Always we receive this question from our colleagues who have a complicated cataract. They refer the patient to us. They know that there is a risk of retinal detachment. They ask us always, they argue why we know that the risk is high for retinal detachment after this complication. Why not to apply prophylactic laser to the periphery, even if we don't have degenerations in the periphery? Actually, this is the answer to this. Let's start with number one. Okay, we don't have evidence to support that if we apply laser, prophylactic laser here, is enough to prevent retinal detachment. The other thing, okay, where to apply laser? The patient, you examine the patient does not have a clear pathology. So where to apply the laser? Should we apply 360? Okay, where to apply? At the equator? Okay, anterior, posterior the equator? Okay, if you want to apply laser to be prophylactic, this laser should be very extensive. 360 should be 4 to 5 rows, and this is very invasive. So this might lead to some complications like epiretinal brain itself, and we don't know if it's actually prophylactic 100%.
Dr. Nabil, we usually sometimes encounter patients with pathological myopia, -12, -13, more than that. And we know these are very prone to expulsive hemorrhages and detachments.
Yeah.
How do you, as a vitreoretinal surgeon, if you have to anticipate and go for the cataract surgery, how will you anticipate and do the preps for this cataract surgery?
Yeah, as you mentioned, these patients are particularly at very high risk of retinal detachment. So again, what we do, we examine this patient thoroughly, okay? I prefer to do scleral indentation to these patients to examine the peripheral retina and check for peripheral degenerations, retinal breaks. If we have, I will be more prone to do laser, low threshold to do laser for these patients more than the regular population.
So prophylactic laser in high pathological myopia better to be anticipated, and then
but for particular degeneration, not prophylactic as only peripheral ones.
Okay. If the patients develop after even for complicated cataract surgery, retinal detachment, or hematogenous, what is your usual approach in the hospital? How Dr. Nabil Refka approaches his patients in such cases when after surgery they have developed it, and you see, for example, in 15 days or 1 month there is detachment. What is your approach, Dr. Nabil?
Okay, usually we prefer in these patients to do pars plana vitrectomy. Okay, we know we have multiple options to fix retinal detachment. We might go for pneumatic, scleral buccal, pars plana vitrectomy. We have many options actually, but in these particular cases, we prefer pars plana vitrectomy for many reasons. One of them is the patient is already pseudophakic. So, you know, when the patient is phakic, we are afraid from causing cataract for the patient. These kind of patients are already pseudophakic. This is number one. The other thing, these patients are usually old. So we expect PVD, we expect liquefied vitreous. So the pars-plana vitrectomy procedure for these patients are usually easy. So our go-to procedure for these patients usually is pars-plana vitrectomy.
Right. Well, Dr. Nabil, it was a very informative discussion, and I know you how much busy you are with your schedule, patients, research, and also management things. But in spite of that, you gave us time, accepted our invitation. So I want to thank you on the behalf of our audience, our YouTube channel, and other audience who are watching this video. I hope it will be very beneficial for our ophthalmologist colleagues and their clinical practice. Thank you, Dr. Nabil.
And thank you, Dr. Alim. Thank you again.